Good morning. Thank you for joining this meeting. My name is Jamie from Surgical Oncology Division of Dr. Sutomo Regional Hospital, Surabaya, Indonesia. Today we will learn about the management of well-differentiated thyroid cancer. As fellow surgeons, we all are learning about this type of cancer, especially about the surgery and post-operative management. In addition to that, there are many more to learn from this topic. This knowledge would help us to better understand and create individualized therapy for our patients suffering from this cancer. What's new? Differentiated thyroid cancer still poses as a challenge and there are many controversies about its management, especially for its treatment. So let me start the presentation sequentially from the epidemiology until the follow-up. I hope to make it brief and informative and I hope there would be many discussions after. So the epidemiology, there is a twofold increase in prevalence of DTC in the past 2 decades, which is caused by the higher sensitivity of testing and the findings of micropapillary carcinoma. This cancer has good prognosis and the mortality rate remains stable 1 to 2%, and both papillary and follicular type consist of 60% of total thyroid cancer. Epidemiology studies show that women are affected 3 times as often and men twice as likely to have cancer-related death. In Indonesia, however, in our country, global cancer statistics gathered and exhibited that thyroid cancer as fifth highest prevalence cancer on women and 11th on both sexes. However, there is still limited data about the exact number of DTC, and this calls for a better cancer registry for thyroid cancer in Indonesia. So what should we do when we find patients with thyroid node or stroma? We should do an orderly diagnostic workup from clinical, laboratory, imaging, and cytopathological tests. I highlighted blood test here to emphasize that it isn't just an adjunct test, but as a sequence to do after clinical examination. Molecular testing here is underlined because it's the future. There are and will be many more research about molecular testing to help us better understand the hallmark of thyroid cancer and its susceptibility for targeting therapy. Okay. So just as like other type of cancers, DTC displays symptoms and signs of progressivity, invasiveness, and metastasis. We could gather the history by asking the location and onset of nodule along with its progression and infiltration to surrounding tissue. We could also gather information regarding the regional and distant metastasis. Papillary type generally metastase to neck regional lymph node, whereas follicular type commonly metastase to skull, brain, lung, or bone. Concerning the thyroid nodule, we should also ask about the hypo or hyperthyroid symptoms to assess its functional status. The history taking should include also the risk factor and past treatment related to thyroid node, and lastly, the comorbid of the patient. Okay, so next is the physical diagnostic. And after history taking, we progress to physical examination. It should conclude both general and locally-regional examination. In general examination, we determine the performance score and head-to-toe examination to evaluate hypo or hyperthyroidism and metastatic signs. Basal metabolic rate is an objective test that could be used to determine your body metabolism, which can then be used as a surrogate testing for hypo or hyperthyroidism. Inspection and palpation of the primary tumor and regional lymph node must be done to evaluate the site, shape, size, and behavior of the thyroid nodule. Specific sign for thyroid nodule can be done in a chunk, for example, Berry sign to evaluate the encasing of carotid by the primary tumor, the Cocker sign to suspect the tracheal infiltration, and Pemberton sign to discover superior cava vein syndrome. And then laboratory tests should be done after the clinical examination. In 2015, the American Thyroid Association recommended strongly that thyrotropin or TSH should be measured after clinically or incidentally discovered thyroid nodule. If the serum is normal or elevated, then thyroid scan, sorry, then we progress to the ultrasound. But if the thyroid scan if the TSH is subnormal, then a radionuclide thyroid scan should be done. Whereas thyroid globulin level is not sensitive and could be elevated in most of thyroid disease and not routinely measured for thyroid cancer test. The next step is thyroid ultrasound, which is a great diagnostic tool to evaluate the thyroid parenchyma, along with its size and location of nodule and lymph node. In this slide, we could see some of malignant characteristics of thyroid mass, such as the composition, the echogenicity, the irregular size, the margin, and the microcalcification. After the sonography, clinician and radiologist should work together to determine the stratification of sonography findings for further diagnostic steps. One of the widely used stratification is the thyroid score. And then we do the fine needle aspiration because it's an accurate and cost-effective tool for diagnosing thyroid malignancy. Fine needle aspiration cytology is recommended for nodules depending on its size and sonography findings. However, we must understand that each 1 centimeter nodule carries its own risk of malignancy, whether it's solid or kystic, whether it's uninodular or multinodular, and the highest rate for malignancy is seen on retrosternal stoma with up to 70%. As we can see in this slide, it will be easy to determine the type of cancer if the finding is obvious, such as the orphan annii or the Samoma bodies for PTC, and angioinvasion or the extracapsular extension for follicular type. However, on the other hand, there are some indeterminate findings such as the atypical lesion and follicular neoplasma. So after we classify the cytology with Bethesda system, if we find such findings, it is wise to re-examine the clinical and ultrasound examination, and if it's necessary or possibly we must repeat the fine needle aspiration or go straight for the molecular testing. And so there are many other radiological and pathological tests for the diagnosis. For example, the scintigraphy is used to identify the functional thyroid status or the metastasis or the ectopic mass. But it's still not cost effective and still needs FNA for the confirmation. And the others, such like CT or MRI, is beneficial to determine the extension of the primary tumor. Such cases are shown in tracheal infiltration, which needs CT to establish the degree of infiltration and further be classified with Shin classification before we resect and construct the trachea. Core biopsy is used for molecular testing to determine its cancer type or to investigate the targeting therapy that can be used for the management. Before we begin the treatment, we should identify and determine the extension and metastasis of the primary tumor. AJCC provides us classification with easily understood TNM. T stands for the primary tumor, N stands for the regional lymph node metastasis, and M stands for the distant metastasis. Besides the classification, risk group stratification are great tool to perceive the prognosis of the patient. There are many stratifications such as age, and then the AIMS and MAGES are the ones used by the cancer center like Memorial Sloan Kettering or the Ohio State University. What we must know is that whatever group we are using, patient's factor and tumor factors define the prognosis. Identical to other type of cancer, differentiated thyroid cancer treatment consists of local, regional, and systemic approach. Surgery is the gold standard for local regional treatment, while radioactive iodine, or RAI, is the mainstay therapy for systemic approach. This represents the steps for conventional thyroidectomy, and every surgeon must have their own trick for doing the thyroidectomy. But whatever you do, please do it sequentially and understand the anatomical landmark to minimize the complications. Remote access and robotic surgery are also gaining new fame as potential surgical therapy. As far as I know, the key for success is good patient selection because there are many bias regarding the surgeon and the learning curve. However, there are still pro and contra for the management of the primary tumor and regional metastasis. Whether we should do the uh, ismolobectomy, not total thyroidectomy, or total thyroidectomy, and whether we should do the prophylactic neck dissection. The debate goes on with key points discussed like the thyroid remnant function, the prognosis, and the complication rate. My opinion, as an oncologist, we must understand that the endpoint of our therapy are three goals only: to lengthen the overall survival, to avoid the disease recurrence, and to improve the patient's life quality. So please base your individualized therapy revolving on those points. To fight controversies regarding the primary tumor management, NCCN in 2019 gave recommendation for primary tumor management based on the recurrence rate and the survival. For bilateral tumor or the tumor larger than 4 centimeter, the poorly differentiated type with history of irradiation or with metastasis, both regional and distant metastasis, we should choose the total thyroidectomy. What's next after surgery? After the surgery, we continue with the wound care and the complication management. And then we must not forget that we have to follow up the patient to identify and treat the recurrence. The algorithm dictates that after partial thyroidectomy, we do clinical and ultrasound examination regularly to find any sign of recurrence. After the detection, if the recurrence is found on contralateral thyroid remnant, completion thyroidectomy is mandatory. After that, we will determine if the patient must get RAE as adjuvant treatment, or we follow up to diagnose local regional or distant metastasis. This table on the right side showed recommendation for RAE indications. And so if RAE is being considered based on clinical pathological features and risk, the radio-oncologist prepares the therapy 6 to 12 weeks after the surgery. Consider the pre-treatment of iodine scan to diagnose if the tumor could still be resected, and iodine scan can also be applied for the therapy baseline. The effectiveness of the therapy depends on the TSH level elevation. So you must raise its level either by the withdrawal of TSH suppression therapy or recombinant TSH. The dose of ablation varies depending the size and site of the residual tumor. In response to that, the American Thyroid Association recommends that minimum of 30 up to 100 microcurie employed to achieve the successful ablation. Okay, so this is the algorithm for the surveillance. About the follow-up, this algorithm shows that what tools used for surveillance and when we use it. Based on the clinical pathological view, American Thyroid Association divides thyroid cancer to 3 degree risk of recurrence: the low risk, the intermediate, and the high risk. The main principle between the surveillance is the higher the risk, the surveillance must be more aggressive. And in this slide, we can see that we can use the clinical examination and then the laboratory examination such as the thyroglobulin or antibody thyroglobulin and the ultrasound. So this is the stratification that I recommend, that I mentioned. In addition to the surveillance means, this grouping is also needed to adjust the length of the adjuvant therapy. So next we talk about the TSH suppression therapy. Hormonal therapy using levothyroxine is employed to suppress the TSH level. High TSH level would feedback our brain to release more thyroid-releasing hormone, which would proliferate any thyroid remnant. The pills are best taken on the morning before breakfast, which could impair its absorption. And ongoing therapy needs maintenance on its efficacy using the TSH level, and we must be aware of the side effects. Until when is a great question, because until now, there are no consensus about when must we stop the thyroid suppression, but all of the journals points that there are follow-up of 7 to 8 years for the thyroid suppression therapy. But after that, should we use the suppression therapy or the replacement therapy? It's still an ongoing debate. Targeting therapy is a promising systemic therapy in DTC, especially for patients with RI refractory tumor. There are many phase 2 and drug trials involving tyrosine kinase inhibitor, multi-kinase inhibitor, and angiogenesis inhibitor. However, there are several factors that must be considered before and during the therapy, such as the side effect and the cost. After all, targeting therapy can only prolong the progression-free survival, and surgery still remains as one of the best curative methods. Picture speaks louder than text. This is a courtesy from one patient from the head and neck division with refractory FTC after total thyroidectomy and RI. If we do the guideline sequentially, then it maybe will be easier for the patient. But what about recidive patient or refractory patient? This calls for discussion. Right now, the patient is undergoing the external radiation for his metastasis. And in summary, there are some goals in management of DTC. First, we must diagnose and stratify all patients to offer individualized therapy. And second, we must treat the patient based on evidence-based medicine, while definitive management of primary tumor is still the benchmark of our care in DTC. And lastly, good monitoring after surgery and timely intervention on recurrence are necessities to prolong our patient's survival. The question is, have we done it correctly? Thank you for your attention. Hope it will be helpful, and we will begin the discussion shortly. Thank you. Oke, selesai.